Dr. Jamie Robertson, and Dr. Andrew Ross. Dr. Jamie Robertson is a clinical ethicist serving the University of Alberta Hospital, the Stoller Children's Hospital, and the Mazankowski Heart Institute. As a member of the Alberta Health Services Clinical Ethics Service. She is a doctorate in philosophy from York University and completed a fellowship in clinical and organizational ethics through the Centre for Clinical Ethics. She was subsequently employed as a clinical ethicist by the Centre for Clinical Ethics, providing healthcare ethics support in a range of environments, including academic health services, community hospitals, long-term care, community care, and specialized mental health facilities. Dr. Robertson is also an adjunct member of the Doster Center. Dr. Andrew Ross is a clinical ethicist serving the Glenrose Rehabilitation Hospital, Cross Cancer Institute, Edmonton's own suburban and rural acute care, community mental health and addictions, and emergency medical services as a member of Alberta Health Services Clinical Ethics Service. Previously worked at Covenant Health Ethics Center and at the University of Melbourne Office for Research Ethics and Integrity. Dr. Ross completed his doctoral studies in philosophy at Queen's University. In addition to his role and work in clinical ethics, he has a long-standing interest in research ethics as well. And Dr. Ross is also an adjunct member of the Doster Health Ethics Center. So without further ado, I pass it over to you, Andrew and Jamie. Thank you again for both being here.
Thanks, Michael. And thanks everyone for joining us. Hopefully we'll have some time for, should be an interesting conversation at the end of the presentation as well. But if you think of comments in the middle, please do feel free to put them in the chat so that you don't forget your thought. Today, we're going to be talking about, as the title says, ethical debates at the frontier of organ donation, and specifically in the area of normothermic regional perfusion, which we're just going to say NRP most of the time because that's quite a mouthful. So, quick overview. We'll start by reviewing some fundamental ethical principles that guide organ donation practice. Explore some ethical controversies related to NRP and how they inform or are informed by these fundamental principles of transplant ethics. We're going to argue that some hidden assumptions may actually be affecting individual stances on some of these controversies related to NRP, and identify some existing strategies for managing some of the areas of controversy. So before we get into the history and the more technical parts, I would like to start with a couple of classic thought experiments from the philosopher Philippa Foot. So the first of these is called the trolley problem. I'm sure many of you have heard of this before. A villain has tied 5 people to the tracks, and probably while twisting his little mustache, and a trolley is coming, and it can't stop in time to avoid running the 5 people over. But you happen to be standing next to a switch lever, which would divert the trolley onto a different track, thus saving the 5 people. Unfortunately, a different villain has tied 1 person to this other track. So the thought experiment is, should you throw the switch? On the one hand, by throwing the switch, you ensure fewer people are killed. On the other hand, by throwing the switch, you're personally causing the death of one of the 1 to save the 5. And so this thought experiment is used often to illustrate the difference between utilitarian reasoning, i.e. the idea that you should act to maximize good outcomes, and deontological reasoning, i.e. the idea that you should act in accordance with moral rules. So the second thought experiment, which is called transplant, is essentially a variation of the first. In this thought experiment, imagine you're a doctor with 5 patients in dire need of organ transplants. You just happen to have 1 who needs a liver, 1 needs a heart, 1 needs a pancreas, 1 needs kidneys, 1 needs lungs. Now imagine that a 6th patient comes in with some minor ailment, and the 6th patient happens to be an ideal match for the needs of the other 5 patients. So is it okay to kill the 1 patient to save the other 5? And spoiler alert, no, it's not. Certainly in actual life, we would say that's going to be a no. But the point of this is that one of the things that these thought experiments demonstrate is that solely focusing on net benefits, as pure utilitarianism advises, can sometimes imply that we should commit some abhorrent acts. So one strategy that exists to try to solve this problem is to draw on both utilitarianism and deontology. So we should still try to maximize utility, but do so only by acting within the constraints of, mutually agreeable rules, or moral constraints that take that rule form. And this is more or less what has actually been done in the transplant world. I don't think that they were thinking about Philippa Foot when they came with the rules that they have, but it's just sort of a happy coincidence in a way. There are a number of rules in place, but today we're going to focus mainly on two of those, which is mitigating conflicts of interest and the dead donor rule. So for managing conflicts of interest, in modern organ transplant practice, great care is taken to manage the competing interests of potential organ donors and potential organ recipients. And so, unlike in the thought experiment, where one physician was responsible for the potential donor and the potential recipients, there's separation between those caring for the donor and those caring for potential recipients. And in addition, conversations about organ donation are meant to take place only after a decision has been made to withdraw life-sustaining treatment, and also ideally, with a different clinician than the one that had been treating the patient as well. So next we have the dead donor rule. As the name suggests, this rule holds that vital organs can only be procured from a donor who is already dead. Also, donors may not be killed in order to make their organs available for donation. And so you can see how straight away this rule, makes quite clear, if we're thinking back to that thought experiment, that you simply should not, under any circumstances, kill the one patient to save the other five. Even though you're saving five and only killing one, it's still wrong. And so this rule plays, in addition to sort of solving that quandary in a way, also plays an important role in maintaining public trust in the system of voluntary organ donation. And I don't think it's controversial to say that a lot of the controversy that surrounds NRP actually has to do with concerns that it may somehow violate the dead donor rule. So with that, I will hand over to Jamie.
And I am going to try and take us, to kind of thinking about more practically, like, what is this thing called NRP? And then we can start to dig into the ways in which it becomes a concern, but based on both of the, potentially both of the values that Andrew highlighted, but especially the dead donor rule. I am going to take us on like a little bit of a historical tour before getting to that point, just because I think it's really useful. As I've been learning more about this topic, it's really been astounding to me to kind of see the way in which controversies in transplant ethics have played out, and in particular, the way in which the heart, like the organ, the heart, has been at the center of a number of really important sort of questions, and has been kind of like a flashpoint in transplant medicine. And so, we're in this sort of continual process of navigating sort of transplant ethics issues, and navigating differences of perspectives around these issues, but they do kind of have this sort of interesting, I think, continuity potentially. So to start off this sort of short history, I think probably this will be familiar to any of you who are working kind of directly in the transplant space. There were donation, like transplants, conducted before 1962, but they involved, as far as I understand, mostly or like living donors. And so in 1962, it was sort of widely marked as like the year in which a organ was transplanted from a deceased donor that was unrelated to the recipient. And this was done after a determination of death by cardiac criteria, presumably, because as we will see, sort of what it means to be declared dead by neurologic criteria was defined, at a few years later. But actually, even before that happened in 1967, there was also the first heart transplant, and it was conducted by a Dr. Barnard out of South Africa. And also, again, this was a person who probably at the time would have qualified as dead by neurologic criteria, but he even waited because, again, there was this uncertainty about, the line between life and death, and the sort of consensus around, feeling confident that somebody was dead after they had, sort of reached this kind of agreed upon sort of circulatory criteria. But even this first heart transplant, was, again, one of those flashpoints around, whether or not, we should be doing what it is that we do with transplantation. Concerns were sort of raised around like, well, if we could restart this person's heart in another person, why wouldn't we just restart it in the chest of the person whose heart it was? There were kind of Dr. Frankenstein comparisons, and, worries, people who are starting to worry that organ donation was going to, or at least deceased donation was going to require killing patients, essentially. So again, these ideas that like we are potentially killing people in the transplant context are kind of long-standing concerns. And then indeed, as I flagged, there was just a year later, a development of a sort of brain-based definition of death out of Harvard University. And so that, again, also was the source of some controversy, but was also kind of pretty quickly adopted over the next decade or so. Andrew, if you could just switch the slide. Actually, yeah. Yes, if you could, there we go. And so just like to be very clear, right, essentially all deceased organ donation, at least per my reading, prior to this sort of Harvard-based, brain-based definition of death was being done on the basis of, death by cardiac criteria or circulatory criteria. There had been some experimentation with people who were in what was called like coma de passé at the time in some circles, which essentially, again, was like that kind of neurologically dead state. But again, until 1968, that wasn't really sort of a fully recognized term. And so again, most of the donation from deceased donors was done after death based on circulatory criteria. And what was sort of interesting as I was reviewing the literature was that there actually, like, after this development of, a ability to declare death based on neurologic criteria was kind of this, some authors are calling an unofficial moratorium on donations from donors who were deceased and declared deceased based on circulatory criteria. And again, it wasn't necessarily anything that was like, like there was, from what I could read, no like official statement, no important changes that people could point to say that, we like that everybody was agreeing explicitly, not to use this practice. And it did continue to be used in some places, but a lot of the deceased donation did switch to circumstances where somebody had been declared dead by neurologic criteria instead. And when you read some of the authors on this point, what they will say is there were a few sort of considerations. One was debates, just as we had seen in sort of 1967 around, whether or not people who had been declared dead by cardiac or circulatory criteria, and then were sort of put through transplantation, whether they were sort of really dead in the necessary way. Just the emergence of this new way of determining death was felt to be by some people sort of more certain or objective. And then, of course, there was a consideration around the ability to continue to have sort of oxygen pumping through organs in the circumstance of a death by neurologic criteria. So there was less damage to organs coming from those donors. And I think, Andrew, if I just, oh, good, yeah, okay. Oh, and so if you could actually just go back one. So you can see I did flag sort of the period of time, sort of late 60s through the 70s, in which the dead donor rule really coalesced, that rule that Andrew was talking about. And again, this is like a very limited history here, but just you can see in the slide that, things developed rather quickly and, really, technology advanced, all that kind of thing into the 90s. And so by the 90s, basically the availability of donor organs became a major limit on transplant. And that prompted the reconsideration of, where we should be procuring, or like which deceased donors might be appropriate to procure organs from. And I'm going to talk in that again was a flashpoint, a point in history where things became quite controversial. And sort of that controversy lasted well into the 2000s. So yeah, so I'll just tell you a bit about that controversy, because I think, again, it's useful history, because I think it's part of the legacy that we are living with now when we think about the sort of challenges that are being raised about NRP. So yeah, so the University of Pittsburgh was one of the first institutions, at least in the States, to kind of start to think about, okay, well, we have lots of people who require organs. We have shifted most of our practice to be sort of accepting donations of organs from donors who are deceased by neurologic criteria. And so they took, 2 years to develop sort of a protocol, both using sort of internal debate as well as external review, to come up with a system by which they would sort of reinitiate the practice, again, that had been the original practice of transplant, or at least deceased donor transplant, which was to also accept organs from people who had been declared dead by circulatory criteria. And part of what this protocol included were actually 2 really important features that are sort of in line with what Andrew was pointing to, including this idea that we needed to manage conflict of interest. And so we need to have different people approaching the patient or family about different questions, treatment versus donation. And then also what they did was they established a hands-off period. So after a person's sort of life support had been removed, usually that was the context, eventually their pulse would stop, and then there would be some time where they, we would do nothing. We would make sure that the pulse didn't restart, they didn't start breathing again, anything like that. And so that was, again, an idea that was seeded and then further developed after this protocol, but sort of started off here. And if you'll switch the slide, Andrew. But what you will sort of learn as you read the history is that this also was a really heightened moment of sort of medical, legal, and ethical controversy. And there were many, many controversies that were sort of brought forward at the time in terms of the rights and dignity of the donor, patient and family choice, conflicts of interest, public trust, implications for individuals with disabilities, the importance of transparency, and the need to be sensitive to differences in culture or religion around end-of-life issues. And so, as this practice was being resumed on a sort of broader scale of accepting organs from people who had been declared dead by circulatory criteria, there was actually a lot of work that was done by various kinds of national and international bodies to try and make the sort of protocol as standardized and as clear as possible so that we could continue to maintain public trust and continue to be confident that, we were acting in alignment with those fundamental values that Andrew had talked about. And so, despite these controversies, protocol for donation after circulatory death were established and kind of again expanded in their use. And over sort of the late 2000s into the 2010s sort of area, there seemed to be, some, I'm not even sure how to describe what it was, because I was like an uneasy status quo, something along those lines. In any case, like there's some people, obviously, as you can see on your screen, who were very critical, but there seemed to be kind of an equilibrium that had been struck in terms of the use of deceased donation from now both people who had been declared dead by neurologic criteria as well as by circulatory criteria. And so just to give you a brief summary of like where we are today, this is the 2023 data from both Canada Blood Services and CIHI. I'm sure actually the 2024 data is probably being released like today, and I'm sorry, but we have not updated the slides. So, the 2024 data should be up to date pretty soon, but we're going to use 2023 because that's what was available last week. And so what it does show you is that, we are accepting organs from, again, a number of different kinds of deceased donors. Donations from people who have been declared dead by circulatory criteria is still an important, sort of part of that group. And in fact, deceased donation accounts for basically the preponderance of organs that are used in transplants in Canada. And so you can see that, anyway, that sort of hashes itself out in a couple of different ways on the slide there. And what you can also see is that Canada has a deceased donation rate of about 24 donors per million population. And you can also see that in 2023, 214 Canadians died while waiting for an organ. So if you'll go to the next slide there, thanks, Andrew. And so, yeah, so, I think even those, sort of that previous slide kind of starts giving you some suggestions about what some of the lingering challenges are that NRP, which we'll talk about in just a moment, is trying to respond to. So you can see that, there's still lots of demand for organs, and, the availability or the demand outstrips the supply. What you could also see is that although there had been a big sort of increase in sort of donation rate between 2010 and 2019, that number of like 24-ish donors per million actually has been kind of consistent since about 2016. It's been like around 20-ish donors per million. It's went down a little bit during the pandemic. 24 is a bit on the higher end, but like it has not been the increase after 2016, at least as far as I could see, was not like the same as it was between 2010 and 2016. So there has been this kind of stabilization, it seems, roughly, of the sort of rate of donation in Canada. And still lots of people are on the waiting list. And so one of the, so with all that sort of taken into consideration, we can sort of understand that, folks who are involved in organ donation might be looking at, well, what strategies do we have to be able to, with a relatively stable rate of donation, what opportunities do we have to increase either the number of organs that we can use from those donors, or to increase the quality of those organs? And, one of the things that we kind of, or that the literature sort of reflects, is that, we still end up with kind of the challenge around donation after death declared by circulatory criteria, in that, these organs can be damaged. And so that can, again, just because of that like process of dying that the person goes through after their life support is withdrawn, and then that hands-off period. And so that sometimes means that fewer organs are usable, and it means that some of the organs might be damaged or poor quality. And so again, we're in this mindset of like, well, how do we address that problem? And so the current practices, again, this is from the literature, and I had a physician review, so hopefully it's accurate, but this is the ethicist attempt to explain what is going on. So our current standard practice is, in terms of preserving organs and sort of preventing ischemic damage, which is again that damage from lack of oxygen, is to flush it with cold sort of preservation fluid and then like immerse it in that fluid. There are some problems with this approach. The tissues can be damaged both by, again, the lack of oxygen, both by the sort of the cold itself, and then per the literature I've been reviewing, also because like by the process of kind of like putting new blood or like reperfusing that organ. So that's part of the challenge. And then it's also difficult to assess sort of how good quality that organ actually is. And if it's a more marginal organ, so an organ that's like not in great shape, there's not really an ability to try and do anything to repair it. And so that's resulted in kind of the sort of exploration of using different sort of approaches to preserving these organs that involve sort of various kinds of perfusion. And again, there's like, you can do it at different temperatures as far as I can read, but I'm going to talk about sort of two big buckets. There's one bucket of alternate process where the organs are removed from the donor, and then they're hooked up to kind of an external perfusion machine. And then you can sort of, again, avoid some of the damage that's sort of associated with the static cold storage. But you can also, assess the function and the viability of the organ better. You can do a bit of like repairing, or again, the doctors out there will know better what exactly that means, but you can kind of fix things, make things a bit better. So you can either do that, as I said, by removing the organ from the body and hooking it up to a perfusion machine, or you can do it by hooking up the body to kind of what's basically an ECMO circuit to perfuse the organs within the body. And again, it has a lot of the same benefits to doing it outside the body. And so that third column is the thing we are talking about today. And so it gets us kind of to our big term for the day, which is this normothermic, meaning at body temperature, regional, so it's just in part of the body, and then perfusion, which is kind of circulating oxygen blood. So it's a technology that circulates oxygenated blood inside the body at body temperature, or inside part of the body at body temperature, again, in a person who has been declared dead by circulatory criteria. In order to facilitate, again, better organ quality, and hopefully the ability to use more organs from that donor. And so there's a number of reasons why people who are in favor of doing NRP want to do it. Obviously, I think I meant it increases the number of donors. So obviously we can potentially get more, or at least we can get more organs potentially from particular donors. It helps improve recipient outcomes because, again, we can tell how well the organ is functioning. It may be because sometimes we're able to use more marginal organs. We might be able to more consistently use the organs that somebody is offering as their kind of final wishes or the wishes of their family at the end of life. And then in addition, again, because presumably sort of doing that outside the body is equally good, there's some advantages potentially over ex vivo perfusion. So the one where you hook it up outside the body. And so, it's proponents of NRP say that it, is actually better even than ex vivo in terms of increasing the number of organs that can be donated by each donor. They will say that it gives even better ability to assess the quality and function of the organs. It means less time without oxygen, not just for like all the organs. And then, again, possibility of reversing damage. And then another important difference between NRP and this ex vivo process is that the ex vivo perfusion requires like a special machine, and those machines are very expensive. So instead, NRP uses existing equipment and doesn't require this investment in this expensive machine. So there's reasons why, it's been a long story, but there's reasons why NRP is being considered, right? We have relatively stable rate of donation. We have a chunk of donors where the organs are coming in a circumstance that aren't really ideal for being able to then use them in a recipient. And we're trying to fix that issue, and we're trying to fix that issue in the potentially best way possible. But that does not mean that this practice is without its sort of without its challengers. So just to give you a bit of, and sometimes like it's important to understand the specifics to understand where some of that is coming from. So there can be sort of two different ways of doing NRP. One is to just do the abdomen, so you kind of like are just reperfusing like the liver and the kidneys and the pancreas. You can also still sort of retrieve the lungs as well in this process, but they aren't actually reperfused. And then there's the one where you actually reperfuse not only kind of the abdomen, but also the thorax, so that both the lungs and the heart are perfused. So again, part of the thing that makes this process a subject of some contention is that it does involve, especially, it does involve circulating body or blood in the body of somebody who's already been declared dead using basically ECMO. And it does involve blocking major blood vessels in and out of the region that's being perfused. And And so that, usually means the head. There is a big concern, as Andrew will tell you, about reperfusion of the head. And so in order to achieve that, especially in the version of NRP that involves perfusing blood in both the thorax and the abdomen, it actually may involve severing some of the main arteries to the head. And so, so that's sort of part of, again, the particulars that make this challenging. We are circulating the blood in a body, potentially involves the heart beating within the body, and we're having to potentially figure out ways to prevent blood flow, particularly to the head. So hopefully that's enough of sort of an explanation. Again, it's certainly the ethicist explanation, and not very scientific, but hopefully it gives you a gist of what exactly it is that this process involves.
Thanks, Jimmy. So jumping back in, well, why is this so controversial? There's a really nice logic model, which any logicians in the crowd will appreciate, and well, I'm not sure how much anyone else will appreciate it, but I liked it. From Shemi et al. 2021 in the Canadian Journal of Anesthesia, and this basically states conditions under which NRP should be morally fine. So the first premise is that if the surgical act of ligating or dividing the aortic arch vessels after confirmation of death, so those are the vessels that come off the aorta and lead to the brain, if ligating or dividing those after confirmation of death and before starting NRP, if that's medically and ethically acceptable, and if death in determination by cardiac criteria is defined by the permanent cessation of circulation to the brain and absence of potential for brain perfusion can be assured to adhere to the principle of permanence for death, then restarting this circulation after death wouldn't invalidate the definition of death. Restarting the heart in the donor's body after death would not invalidate the definition of death, and NRP may be considered permissible. So it seems easy enough, but perhaps not. And I'll just go through a little bit in more detail in those sort of first three premises and show where the controversy comes up. So the first one, I'm going to look at ligation or division of the arch vessels. So again, from the model, if this act is medically and ethically acceptable? Well, so if this doesn't cause the death of the donor because they're already dead, then it wouldn't violate the dead donor rule. But unsurprisingly, some opponents argue, some people think this is not acceptable. And specifically, some will argue that this actually does cause the death of the donor, thus violating the dead donor rule. And the argument being that there's two versions of this claim, and we'll get into that a little bit in the next slide. But the argument is that basically by severing these blood vessels to the brain, we're actually causing death of the donor. On the other hand, proponents of NRP have argued that it's actually not ethically different from other routine post-mortem interventions that are done, standardly in transplant, and that it cannot cause death because the patient is already dead. So on the face of it, I think this is a strange disagreement, right? Are NRP opponents really making some sort of like quantum physics claim that like an action, the ligation of the vessels can cause an effect, i.e. the patient's death, that where the effect actually happens before the action that causes it? Which on the face of it sounds very strange. But I think one alternative explanation is that there may just be different background assumptions between these two camps, specifically with regard to the 5-minute no-touch period of asystole, the sort of the hands-off period where we make sure that the person actually has passed by circulatory criteria, and whether or not that period is actually sufficient to ensure that death has occurred. So the opponent's objection that we're causing death by ligating these arch vessels makes more sense if we infer that they're actually just not convinced that that 5 minutes of asystole is long enough to guarantee that the patient has died. Again, I did say I would get into this, so not all of the opponent's views are reflected here. So some people do argue that this actually causes the death, and so I think this sort of hidden assumption plays into those arguments. Other opponents will actually grant that the patient is dead, but will argue that ligation is maintaining a state of death by preventing resuscitation, which would otherwise occur because of what we're going to do next. But I will say that on that second version of the objection, it's less clear that there technically is a violation of the dead donor rule in that case, because if they're granting that the patient is dead before we're beginning donation. So not to say that there wouldn't be anything wrong with it, but just that it's not clear that it's the dead donor rule that is the problem in that case, from that perspective. So looking at the second, well, this actually was the third in the model, but I'm going to look at it second. Condition is no brain perfusion. So if we can assure the absence of potential for brain perfusion, and the idea being, if the technique succeeds in preventing brain perfusion, then NRP can't resuscitate the donor or, cause them to be alive again, which obviously would violate the donor rule because of the things that we're going to then do after that. Some commenters, both those in favor of NRP and those opposed to it, worry that despite this arch vessel ligation or even division, that there could be what's called collateral perfusion of the brain. So basically that there's a lot of other blood vessels in the body, and there could potentially be enough blood that gets through some of those other vessels that would get to the brain, that this could possibly oxygenate the brain, some parts of the brain at least, to a point where it might potentially restore some brain function. And while I'll just note that while this is an empirical question of whether or not there would be, collateral perfusion, how much it would be and what would be a significant enough amount of perfusion to actually make a difference, it does seem unlikely that there will be a definitive answer forthcoming, at least anytime soon. There are some observational studies being run on this question with sort of small numbers, but I think pretty safe to say there will probably never be a large-scale randomized controlled trial on human subjects, because I can't imagine an REB would ever approve that study. So I think this leads us to our second hidden assumption. Again, it also seems strange that people who agree that we don't know if collateral perfusion of the brain could happen in NRP, they agree that we don't know for sure that it could, whether or not it could lead to resumption of brain function. Nonetheless, those people disagree about whether it's permissible. So are the proponents simply reckless? Are the opponents simply worrying about extremely improbable possibilities? I think one possible alternative explanation is that there are different assumptions being made about the significance of some collateral perfusion, again, related to the previous hidden assumption. So some may assume that we're taking measures to avoid reperfusing the brain only out of an abundance of caution or to stay within a medical legal framework, but actually, this person is well and truly dead. And so even if there were some blood flow, it wouldn't matter because they are dead. Others may be assuming that we are taking such measures because otherwise the patient might still be alive, not necessarily in every case, but in some cases, or might possibly be revived by this process. So this leads us to the last of the three sort of criteria defining death. So again, if going back to the logic model, if death is defined by the permanent cessation of circulation to the brain. And so the idea being that if lack of circulation to the brain is what makes the donor count as dead, then it doesn't matter for the purposes of the dead donor rule if circulation is restarted elsewhere in the body. Some NRP opponents argue that restarting circulation in the heart does invalidate the declaration of death by circulatory criteria. And it invalidates it either because it shows that cessation of circulation to the brain was not irreversible, or because it shows that circulation either that or because they believe that circulation itself, so even just in the heart, is what matters for determining death by circulatory criteria. Proponents, on the other hand, argue that permanence, not irreversibility, is what matters. And this debate between permanence and irreversibility, I think, largely has its roots in the wording of the United States Uniform Declaration of Death Act, and it's a long and not particularly interesting debate, and so we're not going to get into that too much. Unless people have questions, we can talk about it, but I promise you it's not that interesting. It gets very semantic very quickly. But the idea being that the argument is that it's that permanence of cessation of circulation to the brain that matters, and they also will point out that all transplanted hearts are restarted. So it's just a sort of a geography question in a way, rather than an ethical question from that perspective. So again, I think there's a hidden assumption, because at face value, if this were merely about definitions, then changing the medical legal definition of death should resolve the disagreement. And this was actually done in Canada in 2023. But I suspect that many NRP opponents would not be swayed by the fact that there's this new definition. And I've sort of got an extract from that here, which is that death is the permanent cessation of brain function, and that this can result from cessation of blood circulation to the brain after circulatory rest, and or from devastating brain injury. And so this sort of is a unified theory or a unified notion of death, that by either that can be, death is one thing, and it can either be determined by circulatory criteria or by neurologic criteria, but we're talking about the same thing. I do think, though, that this persistent disagreement could be the result of different assumptions about the nature of death, including whether the continued function of the heart or of the brain, or either or both, is what signifies that a patient is alive. And with that, I'll hand it back to Jamie.
So I'll try and wrap us up relatively quickly, but I think that we are, like, that last sort of point that Andrew made gets us into some really kind of deep and important territory. So I am going to pitch this from a metaphysics perspective. So in sort of everyday language, metaphysics is often meant to refer to something that's like spiritual or supernatural, and that's why there are ghosts on your screen. And I just want you to know that, like, that is not the version of metaphysics that we're talking about. A different meaning of metaphysics is, sort of as a technical term in philosophy, where metaphysics is one of sort of the main areas of sort of thought and inquiry, kind of like ethics is. And metaphysics is, among other things, sort of the study of the fundamental nature of reality and kind of the essences of things. And one of the things that I think might be going on in this whole debate is that people may have actually, like, not even ethical, but metaphysical commitments that might not be stated, or they might not even be thinking about, that might really influence their perspective on sort of all of the different sort of views about NRP and the different kind of conditions under which NRP might be sort of ethically acceptable. So I'm going to talk a little bit about what some of those things might be. I'll try not to, like, belabor this too much. But I would invite you to think about, as I'm speaking, oh, are there things about death and its fundamental nature that you are acknowledging for yourself, that you didn't realize that you sort of believed? So the first thing that I would want to talk about is that we might have a lot of differences around even just thinking about like what kind of thing is death. And so again, I have 4 different sort of things we might think about that I'll try and go through relatively quickly. So the first one that I've identified is, we actually might disagree about whether death is one uniform thing or if there are types of death. And so I kind of think about the language that we have had over the last number of decades, the shorthand of like, brain death and cardiac death. And like, has that actually potentially entrenched in some of us this idea that there are actually multiple different kinds of death? And so, when we have people who are objecting to the ligation of the aortic arches because, we are causing brain death, they might have this commitment to this idea that there are like multiple kinds of death, and both kinds of death maybe could happen for one person, as opposed to somebody who might be saying, no, there's just one thing that is death, and it might be caused by different mechanisms, but once you're dead, as long as you're not like resuscitated, you're dead. And so if there's something else that happens, you're not going to have some additional kind of death. There just is no such thing. It's just one mechanism versus another. Another thing that people might be disagreeing about is whether death is actually like a physical, concrete thing, or is it actually more of an abstract, conceptual thing, right? So Andrew, or actually, maybe I'll put it this way, a lot of the ways in which like death is declared in medicine is by looking at like particular, features of a body. And so that would be sort of a very concrete and physical way of sort of understanding what death is, right? It's just when a body is in this physical state. But if instead we actually think what death is that like is sort of a marker of some kind of change in a person, like, when a person ends or when a person's soul leaves the body or something like that, like there are like that's a very abstract, more conceptual type thing. And so no amount of like physical identifiers of death necessarily are going to be able to speak to those abstract conceptual considerations. And so one of the places where some of this disagreement I think might be coming from is that we have again these kind of medical criteria that maybe justify from a medical perspective in sort of declaring death. But I could see somebody who was committed to the idea that like death is the moment when the soul leaves the body, not being very satisfied that like when a doctor says the body meets this criteria, that means like what is it like at that point that the like soul leaves the body. Like that would give doctors an awful lot of power that probably a lot of people who might have this more abstract view of death don't actually agree that they have. So again, one thing that might be going on in the background here is a disagreement about whether those bodily, physical like what the role of those things are in actually speaking to the fundamental nature of death. And it may be that they're just a different kind of thing entirely. The other thing that we might be disagreeing about is whether death is a state versus a process. So, people who think death is a state might go like either somebody's alive or dead, and they might kind of really struggle with things that might be kind of something in between, versus somebody who might, if they see death as a process, then they might go, oh, okay, death, there's like a gradation of things, of degrees of dead that somebody will be, and, lines get drawn for kind of conventional or practical purposes along those processes to allow for various kinds of other things to then happen. And then finally, we might just describe or might disagree about whether death is a description or something that happens to a whole thing or the parts of things or both. And so, it might be that we're people who might be able to say like that, death is when a whole person dies, acknowledging that maybe the individual parts of a person might be, might still be living or have the ability to live. Whereas others might think that, what's necessary for death to really be death is that the whole person and all the parts must be dead. And so I think from my perspective in transplant, there's a heavily reliance on this idea that death is a process and that death is a property of the whole person. And so we're trying to find the point at which the whole person is dead enough not to count as the kind of thing that can be violated by the removal of its parts, and the dead don't, and and sort of for whom the dead donor rule is an important thing. While at the same time, along that continuum, being at the point where some of the parts are alive enough that they can resume functioning in other people. If we could go to the next slide. I might just skip the next slide, but basically it kind of reiterates this idea of like, we, depending on whether we have a very concrete understanding of what death is, or that one of those more abstract ideas what death is, we actually would end up with, very different views on whether scientific advancements or empirical evidence actually changes what we think death is and sort of how it should be established. So I'm not going to dive into this too much, but just to say there are lots of places where we might disagree on very fundamental levels about like the, again, essential nature of death. And that may be causing some of the disagreements, but also again, metaphysics is an ancient sort of line of thought. And probably these are not necessarily things we are going to be able to resolve, because again, they are about these very profound questions that people have been working thousands of years to figure out already. And so, instead we need to think about, well, what are we going to do with those differences? And so I just wanted to flag this paper because folks might find it really interesting, and I'm going to be sort of addressing it for the rest of the presentation. And so basically it's this group, this is kind of like the London and Toronto group that's running this, one of the studies that Andrew was referring to try and establish whether or not there is sort of perfusion of the brain. But they have also kind of gone through the literature for the last couple of years to try and really identify, like, well, what are some of the ethical, sort of quandaries and sticking points around NRP? So if you go to the next slide, Andrew, they came up with a whole big list of kind of outstanding questions. And we're not going to even remotely go into all of them, but there's a few things I wanted to say. So the first thing is that some of those questions are very familiar territory. So this snip is from a paper from like 1993 about DCD, and reading like the last two lines of this paragraph, I was just like, what like decade am I in? Because it just felt so reminiscent of the kinds of debates that are going on right now about societal trust, about the nature of informed consent, and about like how we meaningfully engage patients and families when we're doing something that's a bit new. But I think we do have, again, because we've actually walked this road a little bit before, and we've walked similar roads around other topics before, we probably do have tools for navigating these kinds of differences. And so these bullet points, the main bullet points are questions from that list, from that group of scholars from sort of Ontario. And I just wanted to point out like some of the things that we have, right? Like what is the definition of death that should govern clinical practice? Well, like, what we have established is that like that is a matter of scientific and professional consensus, for the purposes of clinical medical practice. And again, there's probably a process that needs to go on to then determine whether NRP is still consistent with that definition. But to Andrew's point, like we have been refining that definition over time. And consensus probably doesn't mean that everybody has to agree, but it probably should be like a healthy majority of providers. In addition, we might think about like, well, does invalidation of traditional criteria of circulatory death determine or have ethical implications? And similarly to what I was talking about in the metaphysics section, well, like it depends on what we believe the sort of status is of those traditional criteria. Like if they were just kind of like the best we could do to try and have physical representation of this abstract concept, then, violating them may not be immediately a problem. It's more about the nature of the violation or, that kind of thing. And so, the more ethically relevant point may just be that like different people may continue to believe that those traditional criteria are the ones that are most relevant to them. And so we need to navigate that sensitively. And then, yes, thank you. So yeah, and then, we can think about, again, is NRP consistent with dignity that's afforded to human bodies? Well, again, that's like a very culturally nuanced question. And so we don't necessarily have to all agree on, like on so many other interventions that we offer, we don't necessarily all have to agree. But we do need to be able to have, appropriate mechanisms for navigating differences, much as we have for other kinds of practices. You might think about, what level of detail do we need to provide for sort of decision makers when they're making decisions about NRP. And again, we have practices around that. And then lastly, there's a question about like, well, how can we manage moral distress and conscientious objection? Again, we have strategies. So it's not as though we have to reinvent the wheel in order to meet some of the challenges that NRP is now posing for us. So just to summarize, organ donation remains an important treatment, or like organ transplantation, remains an important treatment for organ failure. And there's continuing evolution of the field to try and, do the best for people who are in organ failure, as well as to respect people who might be donating organs. And that has led us to a point where people are seriously considering adopting NRP quite broadly in North America. It's already been, just like to flag, used in Europe for quite some time. But there are ethical controversies. And I think the thing that Andrew and I really wanted to reinforce is that some of these controversies are really about profound philosophical questions that we're not going to necessarily be able to resolve. And so part of what we probably need to be doing is thinking about that toolbox of things that we have, strategies to navigate persistent differences. And so I hope I've been able to give you at least a sense of what some of those things might be.